Welcome to the Physician's Guide to Doctoring, Episode 3, What Every Doctor Should Know About GI Issues, where I interview Dr. Danielle Marino, gastroenterologist at the University of Rochester and currently the Fellowship Director, about things that every doctor should know about gastroenterology. When I say every doctor, I mean like myself, an otolaryngologist, a pathologist, a radiation oncologist. What are GI issues that every doctor should be familiar with? We talk about the fun stuff. Diarrhea. When to be worried about it, when to be less worried about it. GI pain. When is that potentially a catastrophe? And when can you wait a couple days before really starting to worry? What's up with gluten? We get an interesting take on gluten from a gastroenterologist and some fun cocktail party facts about the GI tract. It was a fun conversation. I enjoyed it, and I know you will too. Welcome to episode 3 of the Physician's Guide to Doctoring. This episode is about gastroenterology. We have one of my good friends from medical school, Danielle Marino. Danielle, thank you for being with us today.
Thank you for having me, Brad.
So Danielle and I were at SUNY Buffalo together. And then after we graduated, where did you go?
I did my internal medicine residency at Yale in New Haven, Connecticut. And then I started fellowship at the University of Rochester. And I stayed on there as faculty. So right now I'm an assistant professor of medicine there. And I'm the GI Fellowship Program Director.
Fantastic. Oh, look at what you've done with yourself. So that definitely gives you a lot of street cred when talking about all things gastroenterology. And so today's show, we're just going to be talking about everyday facts that the general population should know about GI, but more specifically, doctors should know. Because, we've all had situations where one of our neighbors asks us for advice, and you might be a pathologist and you don't know anything about gastroenterology except for one or two clinical rotations that occurred 5 or 20 years ago. And so, you're expected to know things because you're a doctor, but they may be completely outside of your specialty. So today, Danielle, I want to talk to you about some things that both of us think that just every doctor should be somewhat familiar with. As a disclaimer, Danielle is employed by the University of Rochester, and I'm a partner at ENT and Allergy Associates. Both of us are currently representing ourselves and not our organizations. And so anything that you hear does not represent the views of those organizations, but are solely of ourselves. That being said, we're also going to be talking about some clinical information, and we can bear no responsibility for outcomes that occur based on advice that you take here. So, as the radiologists like to say, clinical correlations are recommended. So Danielle, let's start off talking about one of my favorite activities, I guess, one of my favorite pathologies, diarrhea.
All right.
So this should be a fun one. So one thing is, let's say the scenario that I have before, my neighbor is mowing his lawn and has to keep running inside because he has very bad diarrhea. So he sees me mowing my lawn and says, wait a second, you're a doctor. Let me tell you about my diarrhea. Yeah.
Yeah, that happens to me regularly.
I would imagine, but hopefully those are your patients and not your neighbors.
But sometimes the mail lady. Sometimes.
Okay. I guess she sees those offers for a job in the Midwest by a lake, an hour and a half from a metropolitan setting.
With a sailboat on it.
Exactly. And she knows that you are being offered gastroenterology. So she kind of figured it out and can now ask you. She's carte blanche to ask you for advice. And you have to give it to her, otherwise you'll get your mail. So diarrhea. So I want to break this down into two things. Really, when is it time to worry? What are we looking for? So what are the important questions that we want to ask said neighbor? Um,
Hmm.
and what are the potential catastrophes? But what are the horses, right? What are the things that it probably is? So first, what are the red flag questions that you're going to ask to make sure that it's not some potential catastrophe?
I'd say the main thing is like, is there blood in the diarrhea? So if it's bloody diarrhea, it's probably something serious. It could be an infection, but if it lasts for more than a week or so, then it's probably something more than just an infection. So if there's blood in it is probably the first question I would ask. Um, if there is, I'm thinking something like inflammatory bowel disease, like ulcerative colitis or Crohn's disease, um, maybe even something like colon cancer. So those are bad. Um, then you want to ask, like, are you having nocturnal diarrhea? So usually, it's normal that people have bowel movements usually first thing in the morning or after eating. And that's because we have something called the gastrocolic reflex. When your stomach distends with food, it leads to peristalsis of the colon and you defecate. And but if you have some sort of pathology going on, that may have you have diarrhea even at night. So usually, if it's at night, that's something organic going on. Again, like inflammatory bowel disease, um, things like irritable bowel syndrome, which is super common and probably the most likely thing causing diarrhea in most people. People wouldn't be waking up in the middle of the night to have bowel movements. So nocturnal diarrhea is definitely a red flag. Um, Blood in the stool. And then I'd say, if it's going on for a long time and it's not abating, if there's any weight loss or signs or symptoms of dehydration, like lightheadedness, dizziness, palpitations, or any other kind of symptoms that go along with it, like vomiting or severe abdominal pain, those are all kind of things that mean that your neighbor should probably go see a doctor and not just talk to you while he's mowing his lawn.
So what can we use to differentiate an ER visit from waiting for an outpatient appointment? So clearly dehydration, if you're showing signs of dehydration, you can't make an appointment for a doctor that may occur in a couple of weeks, right? Clearly
Right.
that's an emergent issue. So
Yep.
if there are signs of dehydration, go to the ER. If there's blood
Yep.
in the stool, so we've talked about this before. Just to take a little aside, um, should they have a hemoccult test?
Oh, Jesus.
Okay,
No. So a heme occult test is called that for a reason. It's looking for occult blood, meaning blood that you can't see. So, I mean, if it's frankly bloody, you don't need to do a heme occult. We know that it's bloody. So if someone's complaining of bloody stool, that doesn't necessarily mean they need to go to the emergency room. I mean, it kind of depends on the situation. If it's a copious amount of blood or if it's just rectal bleeding without diarrhea per se, yeah, that's probably warranting an emergency room visit. But if it's a little bit of blood mixed in with your diarrhea and it's been going on a bit, see a doctor as long as you don't have, signs and symptoms of significant anemia or dehydration. You don't
got
have
it.
to go to the emergency room for that.
So anemia, dehydration, which can have similar symptoms, those would be reasons to go to the ER. Otherwise, just get to your at least your internist, if not a GI doctor,
Yep.
pretty quickly. Okay, fantastic. So you also mentioned GI pain with the diarrhea. Let's say he's mowing his lawn and he's a little slow because he's got a stomach ache. So he doesn't have
Mm-hmm.
diarrhea, doesn't have nausea or vomiting. It's just stomach pain. So,
Mm.
you know, acute stomach pain, chronic stomach pain. Well, let's talk about acute really first. When is this an ER visit versus an outpatient visit?
I'd say, there's a million things that can cause acute abdominal pain. But I think if it's someone that doesn't normally have abdominal pain and they have severe abdominal pain, there's a lot of serious things that could be happening. So if this is a person that has no GI symptoms normally and all of a sudden has severe abdominal pain, no matter where it is, they really should go to the emergency room. It
Got
could
it.
be something serious like cholecystitis or cholangitis, diverticulitis, an abdominal perforation for some reason, a perforated peptic ulcer or perforated colon. mesenteric ischemia. So there's a lot of like serious things that could turn into like a surgical emergency if ignored with acute onset of severe pain. That being said, there are a lot of people that have actually like chronic abdominal discomfort, and people who have irritable bowel or some what we call like functional abdominal pain, which is more of like a nerve related issue. And those people who have kind of chronic abdominal pain may have acute bouts of that. And they don't necessarily need to go to the emergency room every time. I think we need to take it in context of what the baseline is and things like that, and where the pain is, and if it's related to defecation and such.
So clinical correlation recommended.
Absolutely. Always. That's our disclaimer, right?
So if he's saying this is the worst stomach pain of his life, he should probably go to the ER. But if he says, but it's pretty similar to the stomach pain I had yesterday and the day before in the last few weeks, in the last few months, that speaks to the lack of urgency, because there seems to be a pattern.
Yeah. And we've all seen the patients who claim they have 10 out of 10 or 12 out of 10 pain as they're, on Facebook
Scrolling
on their phone and eating Cheetos. So like, you kind of have to take it with a grain of salt and see what, if they've had it before and things like that. But
I actually have a personal aside about my own GI pain, because I have you on the phone, so
free consult.
I'm going to take advantage of the opportunity. Yeah, indeed. It's not a consult. It's just, I think it's an interesting story. So my wife and I were on our honeymoon, which was a safari in Tanzania.
Oh.
So we were on the flight back. Yeah, it was amazing. So we were on the flight back, and I started to get some stomach pain, and it was pretty bad. And it would happen after I got back every time I ate. And I just stopped eating because it was so severe. And I thought it was constipation. So I just tried treating myself with some over-the-counter stuff, and, nothing was working. Mm-hmm. And ultimately I saw GI, I had an EGD, everything was fine. Here's what it was. She was pregnant with our first child. And this is apparently a phenomenon. This is not unheard of for like anxiety. And I'm sure you see this, anxiety related abdominal pain. Absolutely. It had nothing to do with the trip to Africa or having eaten something. I didn't have giardia. It was just because I was anxious because she was pregnant with our first kid. So
as I like to say, the GI tract is the window to the soul. So whatever you're feeling on the inside usually presents itself with, some GI distress, or, they say butterflies in the stomach, all those things are related to kind of what's going on in your life. Stress definitely affects the GI tract significantly. And that's because there's almost as much nerves in the GI tract as there are in the spinal cord and the brain. Mm-hmm. There's like a ton of nerves and neurotransmitters, and it's really complicated between the brain and the gut connection. But definitely they both interact with each other. So stress can cause GI symptoms, and GI symptoms can cause severe stress or anxiety or depression or, other neurological symptoms. So it's pretty interesting.
Yeah.
And it's hard to, sometimes it's hard to tease out, what's an organic, structural problem versus more of a nerve related issue.
Yeah. That's probably one of the things that's more challenging for you to figure out when you're doing your outpatient consults, isn't it?
Absolutely. Definitely. History is like huge. It's all about taking a really good history. And sometimes, patients aren't really able to give you a good history. So sometimes it's difficult. You have to do, some tests that maybe you didn't necessarily want to do, but you have to rule some things out.
Sounds like that is the post-nasal drip of otolaryngology.
I can imagine. Or LPR.
Or LPR. Well, those two things are intertwined. This like mucus sensation in your throat when they have normal nasal exam and laryngeal exam and everything in there, all this throat clearing. Mm-hmm. It can be very, very challenging to figure out. So I guess we all have our own, every specialty has their own post-nasal drip.
Yep.
So that was interesting what you said about the number of nerve endings in the GI tract. So that was something else that we wanted to talk about. What are some other cocktail party facts that you might be able to share with our listeners? Is there anything else that even if you might find it interesting for you and you might think it's boring to us, I doubt that. I think I'm going to find it interesting.
Well, okay, one thing that people don't realize is that like there's no set definition of like diarrhea or constipation. So like it really just depends on the patient, and the variation of normal is pretty big. So we consider normal anything from like one bowel movement every 3 days to up to about 3 bowel movements a day.
The rule of
So
threes, the poop rule of threes.
the poop rule of
So
threes.
so
So as
every
long as you're
every
within
three a
that
day
area.
or every 3 days, all normal.
Mm-hmm. But even, I mean, that's kind of wishy-washy too, because if someone tells me, well, my whole life I've had 4 bowel movements a day, and that's just been me my whole entire life, then that's probably normal for them. And I'm not overly worried about it, especially if it's not bothersome to them. So
It'd be hard to hold down many jobs with a bowel
4
movement
bowel
that
movements a day.
frequently. Yeah, that's gonna my patients would get pretty upset. Really, I'm waiting again because he's again. Really?
Well, that's something that I find interesting. Some people take about 30 seconds to have a bowel movement. And for some reason, it seems many men take like 3 hours to have a bowel movement. It's like, I kind of think you use it as an excuse to like hide away in the bathroom with your phone and like fall down a rabbit hole in the internet or something. It shouldn't have to take that long.
Listen, those patients then end up getting hemorrhoids.
That's
and
true.
keep colorectal surgeons in business.
Oh, here's a fun fact. So you know how
And
we
that may or
sit.
may not include me.
So you know how we sit in this country? We sit on a toilet
Yes.
to go to the bathroom. I know,
Mhm.
Brad, you've done a lot of traveling,
Mhm.
and you see, like in other countries, people don't necessarily sit on a toilet; like they'll
And
squat
squat
down.
toilets. Yep.
Yep. And so that's actually the best way to defecate because it opens up the anorectal angle. There's a muscle that kind of is a sling muscle and pulls on like the rectum. It's called the puborectalis. And when you squat down, that actually opens up the puborectalis muscle and opens up that angle so the poop can come out easier.
I would also imagine that because you're folded up like an accordion, you're also squeezing things a lot more.
Yep, and it helps your abdominal musculature, work better than if you're kind of stretched out. And
Probably good for
so,
your back.
this is why. Have you seen the squatty potty?
Yes, with the weird
The
unicorn
unicorn who poops
commercial.
rainbow ice cream? Yeah.
Are
Yeah.
you? So we didn't do any disclaimers at the beginning. Are you receiving any compensation from the Squatty Potty?
I have no financial disclosures,
Okay, I
but
have
I
no
am a
financial
big
disclosures either.
I am a big fan of the
Unfortunately,
squatty potty because that is the correct way to poop. They're right. So I do recommend that to my patients a lot,
do
and it avoids straining and kind of prevents you from developing hemorrhoids. And it makes a really good Christmas present. I've given it to many people.
really? That's funny because we give for newborns, we always give the snot sucker.
Oh God, that thing freaks me
The
out.
nose, yeah. So
That's funny that we
we
both
give
give like gifts that are related to what we do.
dorm specialties. Yeah. Well, we realize we find it useful. Okay, so
Yeah,
the Squatty Potty seems a good alternative to standing on your toilet seat and then squatting down.
correct.
That's
I have had a patient tell me that they do that though. Like just casually mentioned, oh yeah, my whole life I just put my feet on the toilet seat.
now, was that
Oh,
person
okay.
born in a country where that is a routine
Oh,
thing, or they
no,
just like
no.
decided it was a good idea?
She actually, I think she has a defecatory disorder. She has a
Oh,
problem where her anal sphincter doesn't relax, and she kind of, I
figured it
guess,
out.
realized that without knowing exactly what it was, and kind of worked around it on her own, and never talked to any doctors about it.
So some people self-treat things like anxiety with marijuana, and she self-treats her anorectal dysfunction by squatting on a
Standing on the
toilet.
toilet.
Yeah.
Got it.
Well,
Yep.
that's I have to say that is pretty impressive that she was able to
Yeah.
figure that out and had just been doing it her whole life. That's
Agreed. And when the patient told us that, like when I went back in the room with the fellow was pretty like shocked that
Yeah.
the patient made her own diagnosis.
Yeah.
We were
That's
like,
amazing.
okay, we know what the problem is.
Yeah.
Thanks.
So what
other
about
fun facts
fun
about?
fact? So I have a question, just things that can turn your poop different colors, not pathologies, right? Like I remember there's
Yeah.
something that causes khaki colored poop, right?
Oh,
I don't
yeah.
remember.
Well, like clay colored.
Yeah,
That's when you have like a biliary obstruction. So
got it.
you lose the bile because the bile is what makes your poop brown.
Makes it. Got
So
it.
if you lose your bile, you can have like a white
Sorry,
clay.
clay, not khaki. More of a
That's the new
bone or an
J. Crew,
eggshell. Yeah.
the new J. Crew color. Biliary obstruction pants.
Chinos now in biliary obstruction all fine.
Khaki. Yeah.
But what about stuff that you can eat that will turn
Oh,
your
yeah.
poop different colors?
So beets can turn your poop red.
Okay.
I do not like beets, thankfully, but beets can turn your poop red. Pepto-Bismol can turn your poop black. And a lot of, I can't tell you how many times like we've been consulted for melena, which is, black stool. It's supposed to mean an upper GI bleed. But really it just turned out the patient was eating a bunch of Pepto-Bismol. And so that's why it was black. Iron pills can also turn your stool black.
Well, hence the need for a hemocult, right? Because that's not frank red blood. That's like, I'm not sure if it's blood or not. Like, what about the beet patient, right? Like, then you're doing a hemocult on someone because you can't tell if it's blood or beets.
So you can kind of tell the difference, actually.
Yeah.
I mean, it's red, but it's like a weird red. It's not like a blood red.
That's what I tell my patients about tonsillectomy. So one of the things that you read on the internet after tonsillectomy is don't drink anything red because you won't be able to tell the difference if you're bleeding, which is a common problem after tonsillectomy. You won't be able to tell if you're bleeding or if it's Hawaiian punch. And so what I tell my patients is one of the risks is dehydration. So if all you can get your kid to drink is red Gatorade or Slurpee or Hawaiian punch, like we can tell the difference between Hawaiian punch and blood. Just keep them hydrated.
Absolutely.
It's funny how those misconceptions start.
Yeah. So have you ever smelled melena? I'm sure you've smelled melena. I mean, people know, like you can tell the difference between that.
At this point, I've been doing otolaryngology for 4 years in residency and 7 years, and so 11 years. So if I've smelled melena, it was over 11 years ago. But you know what? I can still remember. I feel like
it's right. It's one of those things that you don't forget.
Yeah, it's one of those things I remember hearing in a lecture in medical school. Yeah, their poop really smells bad. But everybody's poop. Oh wow, yeah, melena. Okay,
yeah, no,
that is a whole.
It's a different level of bad.
So you don't really need to test for hemocult because oh my god, that is room clearing. Yeah.
Right. And hemocult is actually made for colorectal cancer screening. There's really no indication to use it otherwise. It's not to look to see if someone's bleeding because it can have a lot of false positives. If someone has hemorrhoids and they could have a positive
from sitting on the toilet for 3 hours on the at a time.
Absolutely.
Going down a Facebook rabbit hole.
And especially getting like a rectal exam and then doing a hemocult, that's like a huge no-no. Even just putting your finger in can cause some minor anal trauma that can cause the hemocult to be positive. So if someone's GI bleeding, like we'll know. Like, you check their crits. Blood is a laxative. So if they're actually GI bleeding, they're going to be going frequently. They're not going to just have like one bowel movement a day or whatever their normal is. So like they'll declare themselves. We don't need the hemocult. It's not going to help us.
Stop doing hemocult.
And hemocult positive is not a color. So we always ask, what color is the stool? And they'll say positive. No, I've never seen that on a Crayola crayon. It's like red, brown, or black. Like that's what we care about. Or khaki. I mean clay.
Yeah.
Whatever fun facts. So your colon actually sees like 10 liters of fluid every day, and it's like really good at absorbing water. So it absorbs like 9 liters of fluid every single day. I don't know. I find that to be a fun fact.
I'd
put people to a cocktail party with that.
I'll supplement that fact with another fact.
Uh-huh.
You generate 1 liter to 1.5 liters of mucus a day between your nose and your mouth, and that gets swallowed.
That's a lot.
That's a lot.
Ew.
So yeah.
Gross.
So that's the whole postnasal drip. When people are like, but I feel this mucus dripping down the back of my throat. Yes. It's called mucociliary flow. The sinuses and the nose make mucus. It's pushed posteriorly by the cilia
on purpose.
and on purpose in a very intentional way and a very specific way. Actually, you can, if things go off course, you can end up with something called recirculating mucus, and that can be a nidus for a sinus infection. So it ends up getting swept back posteriorly, and then you swallow it. So all of that mucus is post-nasal drip. So it is, in fact, normal. Now, it can be abnormal in the same way that you were saying about the GI tract, right? Like if you absorb a little too, or I guess a little too much, like if you're dehydrated, right? Like you take a little too much water out of your stool, you're going to get constipated and very hard stools, or just a little bit too little, and then you end up with diarrhea. People are very sensitive to the sensation of mucus dripping down the back of their throat. So a little too much in a cold, and it can really bother you. Or if your mouth is really dry, you end up with this very viscous mucus, and people end up spitting and thinking that they're making too much mucus, but really it's just their throat is dry. So it's a little otolaryngology aside for you. So just another aside, please stay tuned because Dr. Marina will be back with another episode if you're enjoying this one. And I hope you are, because I certainly am, about more fun and interesting GI facts. But we'll get a little more technical in the next one. And we'll talk about reflux, and we'll talk about other workups. It may get controversial, and it will certainly get exciting. But for this episode, I wanted to talk a little about gluten. We're going to get a little controversial now. So not celiac specifically, because that is my understanding, it is a pathology-based diagnosis, right?
Absolutely. You need to have duodenal biopsies showing villus blunting to make a diagnosis of celiac.
Okay. But what about all of those other patients who complain about gluten sensitivity and are celiac negative? And just to be clear, gluten is a protein that's present in wheat, and it's what gives dough its stickiness and doughiness. So for the baker side of me, there you go.
Nice. So so there are a lot of people that are sensitive or intolerant to gluten but don't necessarily have celiac. And that's because, we're not really made to digest gluten all that much, and we end up taking in way more than we can handle. And so actually most people would probably feel pretty good on a gluten-free diet. It's hard to do. But gluten is one of those things that gets fermented in the GI tract and can cause a lot of gas and bloating and discomfort. And so there's a ton of people that just, have symptoms with gluten. But it's actually really important to tell the difference between celiac and just gluten intolerance or gluten sensitivity. Because people with celiac, there's actual damage happening to the small intestinal lining that can lead to a lot of other problems like osteoporosis. The chronic inflammation in the gut can lead to things like small bowel adenocarcinoma or small bowel lymphoma. And so it's really important to kind of make the diagnosis. Does this person actually have celiac disease, or can they just not tolerate gluten? And that needs to be done before they go on a gluten-free diet. So a lot of times primary care doctors will have their patients go on a gluten-free diet, or patients themselves, or they'll read on the internet and they'll go on a gluten-free diet and they feel so much better. And then it's really kind of hard to convince them, well, okay, go back on gluten we can test you.
Have this loaf of bread that's going to make you extremely uncomfortable.
Right.
And so we can take a piece of, so we can put you through a procedure where we actually take a piece of you and give it to some other guy to look at under a slide.
Right. It's really hard to convince people to do such things, but it is important to know the difference. And then plus it has, implications for families because it is hereditary. So if patients do have celiac, then we would recommend getting their kids tested and stuff. So it is important to kind of sort that out. But yeah, lots of people just, don't feel too good on gluten. It can cause bloating, abdominal discomfort, diarrhea, gas.
Sounds a lot like lactose intolerance, right? Like we haven't evolved to consume the amount of dairy products that we do in our modern society. And so this is our body telling us that, you know what, a little bit good for you, fine. Keep the, vitamin A and D levels up, but
right. You can
the volume that you're eating.
Lactase. Yeah.
I'm sorry, say again?
You can overwhelm your lactase,
Yes.
the enzyme on your small bowel villi that kind of break down the lactose. And actually, as we age, the lactase goes away. So, like for certain, like European derived, I guess, European ancestry
People of
patients.
European descent, yes.
Descent, thank you. There's a very high rate of lactose intolerance, like as you age. So by the time you're like in your 70s, I think it's like something like 60 to 70% of like Eastern European Caucasians will have lactose intolerance. So it's very common as we get older.
Huh. And can you upregulate it? Like by fighting the good fight and just kind of pushing through?
Just pushing through and eating more and more cheese.
Yeah.
No, that doesn't happen.
Oh. Well, that's unfortunate.
It is, because I love a good cheese.
Yeah.
But fortunately, I have not yet developed lactose intolerance. That will be a sad day.
Those European cheeses are some of the best. My wife is Swiss, so we every so often we'll have a good stinky cheese. And it smells like feet, but it's delicious.
Yeah. So the good thing though is that there's like a ton of gluten-free products out there, and they don't taste that bad. So for the people that it does bother, or for the people with celiac, there are good options now. Whereas like a decade ago, it was horrible. There were really good options.
Yeah. I mean, there's like restaurant menus and it's hopefully for the lactose intolerant community, there will be a similar revolution, but
that would be great.
Or you could just take a lactose.
You could do that.
Well, Danielle, this has been Dr. Marino. This has been very informative. Thank you very much for your time. I appreciate it. It was a lot of fun.
Welcome. It was fun.
I can't wait to have you back for future episodes.
Cool. Thanks for having me, Brad.
This was Dr. Bradley Block at the Physician's Guide to Doctoring. Find all previous episodes on iTunes, Stitcher, or wherever you get your podcasts, and write us a review if you have something nice to say. You can also visit us on Facebook. Search Physician's Guide to Doctoring.